session is sponsored by Eli Lilly, and I would like to call upon again Dr. Shirish Alurkar, Senior Medical Oncologist from Ahmedabad. Over to you, sir.
Thank you, Kashish, again. I'm back again on the stage. I hope you guys are not going to push me out of this audience here. So, Dr. Sachin has mentioned about ribociclib. We go to another molecule by a different company, Lilly, and this is a similar CDK/CD4 inhibitor. These are my disclosures or disclaimers here. Yeah, so I'll be focusing mainly on the MONARCH trial, which is the pivotal trial for the approval of this drug, this abemaciclib, which is a CDK/CD4 inhibitor. Again, in HR positive patients, HR negative patients with advanced or metastatic breast cancer. And these are all patients who are what we call endocrine resistant patients. So this was the trial. It was 2:1 randomization between the new drug, which is abemaciclib, in a standard dose of 150 twice a day, along with fulvestrant, because these patients are endocrine resistant. So whenever we have an endocrine resistance, we go away from aromatase inhibitors or tamoxifen and then put the patient on fulvestrant. So, and along with that, placebo, because at that time we didn't have any other molecule to join, and fulvestrant remains the cornerstone of the endocrine therapy. So after a 2:1 randomization, a good number of patients, almost 700 patients, these were all either they were postmenopausal and they were perimenopausal, and they were all endocrine resistant, and the definition of endocrine resistance is very much there in the ESMO guidelines. This patient did not receive chemotherapy for the advanced breast cancer. They could have received chemotherapy and in a neoadjuvant or adjuvant setting. And these are to be noted is these patients had a very good performance status. So as against the clinical practice, what we see, many of the patients of ours are symptomatic. They could have a PS of 2, they could have a PS of more than 1. So these patients in the trial were excluded, so that's what we have to keep in mind. The primary endpoint was the PFS. So if one sees the type of patient, what type of patients are there, the endocrine resistance primarily, these patients, the primary resistance were about 25%, that's about 1/4. The other 3/4 had a secondary resistance. And if one sees the PR status, negative PR is considered to be a poor prognostic feature. So patients having a negative PR are about, again, 1/4 of the patient, about 20%. And those having visceral disease, which is also a negative or a poor prognostic feature, were about 50%. So this basically group trial includes patients with a poor prognostic features, namely the primary endocrine resistance, a negative PR, visceral disease, and those patients may be having a peri or a premenopausal status. The primary endpoint was the PFS, and there was a significant improvement in the PFS as far as the comparison with placebo and fulvestrant is concerned, with about a median PFS of 16 months and a significant p-value here. In the subgroup analysis, one sees the endocrine resistance. Logically, if you see the endocrine resistance, the PR negative status, visceral status would do poorly with any other type of treatment, or even the other, probably the CDK/CD4. But this trial, the MONARCH 3, has shown that even in this subset of patients, if one sees the forest plot, all the diamonds are on the left side to line of unit. It's favoring all the groups, whether it is a PR negative or a PR positive, etc. So it has got a wide spectrum of activity in all spectra of diseases. In the tumor size, a significant reduction in the tumor size. One finds if you see the CR rates are about 3% in the intention to treat population, and total the response rate or clinical benefit rate is about 72% here in the abemaciclib group. The updated PFS, which was there in about 5 years follow-up, was there. It's about 29% versus 10%. Again, a significant improvement with an hazard ratio about 0.53. So about there's a 47% improvement in the or prolongation of the survival as far as the abemaciclib group is concerned. The OS data, not yet this thing, but it is significant, 0.01%, you can say. But still, I think we need a longer follow-up as far as the OS data is concerned. As far as the stratification factors are concerned, yes, in those patients with visceral disease, which are there in the red boxes, and those patients with primary resistance, the diamonds are more towards the left, indicating that these are the patients where the abemaciclib works better. I am not saying that the previous molecule ribociclib doesn't work. There are also data where ribociclib also works, but this trial has the largest number of patients on these sort of subset of patients. As far as the metastatic site is concerned, commonly we see bone only metastasis. Bone only metastasis is considered a good prognostic feature, but if there's a visceral site, we usually counsel the patient negatively. But now with the advent of this molecule, a significant benefit even with patients with liver metastasis. So that could be one of the so-called indication where we can use abemaciclib, but other molecules can also be used. Primary resistance, it works better in those patients who have a primary resistance, as can be seen from the separation of the curves compared to the secondary resistance. One basic endpoint, which is an exploratory point, not really powered in this trial, is the time to chemotherapy. So you have given CDK, CD4 inhibitors, say for 6, 8, 10 months, 10, 12 hours, maybe 1 year, and ultimately disease progresses, and you have to then shift the patient to chemotherapy. So what is that time to chemotherapy? So there is a delay in the use of chemotherapy if the patient has received abemaciclib compared to placebo, by almost about 40%. So there is definitely you can delay the side effects and the toxicity of chemotherapy. The side effects, as far as concerned, they are more or less manageable. Diarrhea is one, and many of the patients we use loperamide, or symptomatically we just have to counsel. One feature of diarrhea, it usually occurs in the first couple of months, and it's about 2 or 3 diarrheas in a day, not much troublesome. We just counsel the patient, encourage the patient, and once the patient crosses that 2 or 3 months, usually she is out of that diarrhea, the toxicity part. So in conclusion, the addition of abemaciclib to fulvestrant in these patients who are endocrine resistant population had an OS benefit about 9.4 months, and this was consistent across all the so-called poor prognostic groups, which were like visceral diseases, or they are say PR negative diseases, or primary endocrine resistance. So and it delays the receipt or the requirement of subsequent chemotherapy when the patient progresses. We need more follow-up, of course, as far as the MONARCH 2 is concerned, for the better OS benefit documentation. I'll quickly go to another. These are all 2 or 3 presentation in tandem. So this is basically the significance of PIK3CA and the ESR mutations in ctDNA. We heard a lecture in the morning, and the FFP samples in patients on this drug. So what they did here is they used, aside from the ER/PR positivity, they were PIK3CA and ESR basically are implicated as a resistance to endocrine therapy. So if you have a PIK3CA or ESR mutation, probably your endocrine arm is not going to work. So that was basically the surmise of this study. And the PIK3CA is present in both the primary as well as the metastatic tumor. So what they did is they, in the previous trial, they found that whenever there is a PIK3CA mutation in this patient, it usually correlates with a shorter survival. As one can see here, in those patients with mutant, the survival is short, and in the wild type tumor, the survival is slightly on the longer, about 16 months versus say 11 months. So it's a negative prognostic factor. So these were the exploratory objectives of this trial. They tried to see the concordance of the PIK3. So they took samples of the blood, they took samples also of the tissue, and then they analyzed whether the PIK3CA and ESR mutations were there and how they correlated. So this is the trial. I will not go into that. And they did, the mutations were seen basically on 4 mutations on each of the gene. So these are the different mutations, say on the PIK3CA and the ESR1, and they tested whether it was present, say, in a digital droplet PCR by specific technique. And they were seen whether it was positive in the tissue as well as positive in the plasma. These are basic character. I won't go into the baseline characteristics of the trial, and the frequency of the mutation if one sees that out of 40% of the patients had evaluable plasma samples, and the concordance rate, that is PIK3CA positivity in the plasma and the tissue, was about 63%. So, but you are still missing about 40% where there will not be concordance. So either the tissue will be positive and the plasma will be negative, or vice versa. As far as the ESR mutation is concerned, overall, if you see in the plasma, the possibility of having a positive ESR is more, about 64%, compared to the tissue, which is only about 4%. So there is still something required as far as the tissue analysis is concerned. Plasma probably is better for an ESR mutation here. How does it correlate with the biomarkers? Well, I think I'll skip this slide. So as far as the PIK3CA is concerned, in the wild type PIK3 versus a mutant, you can see that in the mutant there is a bigger separation of the curves, probably indicating that those patients with this mutation do also. Not that the wild type doesn't benefit. So you can see that this mutation, irrespective of the mutation, abemaciclib does work in both the arms. Same way for the ESR, it works in both the arms. I'll quickly run through the slides. The limitation of this is, of course, is the number of samples. The number of samples here were small as far as the tissue was concerned, and this FFP tissue was collected 3 years before the entry into trial. So when the patient has a progression of disease, one didn't know what was the status. Ideally, we had to do a rebiopsy or take a sample and see what is the status. But PIK3 mutation is one which is usually in existing right from the beginning of the metastasis of the disease, so it doesn't change really. Okay, so quickly go through, we have about 4 minutes, so I'll quickly go through a case which is a real world sort of case which I did there. Yeah. So this lady is a 62, a postmenopausal lady, mass in the right breast, 1 year, with right hip pain. And when she came to my clinic in OPD, she had a fungating mass involving almost the whole breast. And this was in September 2020. Biopsy showed a classical infiltrating duct carcinoma, ERPR strongly positive, HER negative, so luminal A sort of disease, and a high Ki67. A PET scan shows a large disease locally as well as multiple nodes in the axilla. Skeletal node metastasis, she was painful because of the metastasis, and bilateral pleural nodule, so she had axillary, pleural as well as skeletal mets. Now, this was the situation in September 2020. We offered the patient chemotherapy. We will ask why, because this is not a classical monarch 3 sort of patient, and today I would have given CDK CD4 straight away, but at that time, and plus this was 2020, the COVID situation. The patient was some government scheme beneficiary. There was time getting the molecule of the CDK, so forth. So her son was an engineer and a professor in a college, said let's start the chemo first. So we started the patient on TAC 6 cycles, which was given up to about January 2021, and clinically there was a very good response, although this was an ERPR positive case. PET scan in January 21 showed a small mass remaining and almost a complete regression of the axillary. I will show the images. And there was sclerosis of the bone lesion. She had severe pain initially, and now she comes walking, and there was no problem at all. There's no pain, analgesic required. Now, this molecule was available. This was January 2021. So now this patient was put on abemaciclib along with letrozole, because this was the first line therapy based on the monarch 3 data. And she tolerated this treatment well. It took for 4 months. The whole mass in the breast was totally shrunk and fibrosed. There's nothing there actually. Again, the son decided why not go for surgery. In the tumor board, we decided to go for surgery. She underwent an MRM, although this is not the standard of care. This is what I would like to specify here. It was the dermis involved, and advanced disease PT4N2A, and she remained ERPR positive. And incidentally, the Ki67, which was about 50 or 60%, we did a Ki67, it was about 20% only. She continued with abemaciclib, letrozole, and in a PET scan in August showed almost complete regression in all the disease, including the pleural site and the skeletal sites. Later on in December 2021, so almost a year when she started. She just started in January, and in December there was one small lesion in the segment 6 of the liver, which I'll show the images now. So this was the mass initially. When she came, a large mass, you can see the skin being almost pulled back, so the fibrotic mass out there. And after 6 cycles of TAC, seems to be better. Clinically, she was much better. This mass has considerably reduced. And in August 2021 and December, these are different scans. This was almost complete resolution. Nothing is seen practically in these scans as well as clinically. In December 2021, there was this arrow points to a small lesion in segment 6 of the liver. Again, the same scan here. We did a biopsy from the liver SOL In Jan 22, it showed same features suggestive of breast cancer, again luminal type A. Again, a tumor board, SBRT was given 25 grays. We also, because not much, she also underwent a 58 gene somatic mutation. That's what the son wanted, because thanks to the Google. But we are stumped because we got a CDH1 mutation. What to do with it, I don't know. It was PIK3SA wild type, so again, nothing much beyond that. At present, she continues on abemaciclib. She is fully active, attends to her usual daily household chores, and in metabolic CR, including the liver lesion. She is fully active and about. So this basically case presents what we usually face in our clinical practice across the table. Many times the guidelines are there, but we have to do something like a tailor-made therapy. Thank you. I think time's up. Thank you.
So, Shirish, 2 comments. For a 62-year-old metastatic breast cancer, I would never use 3-drug combination. Your comments on that?
Sorry, 3-drug?
For a metastatic 62-year-old lady, I would never use a 3-drug combination.
Yeah. Okay.
3-drug chemotherapy combination.
Yeah, so that would exactly. I would agree with that. But my individual choice, I am quite comfortable with TAC. A lot of my patients are on TAC. They tolerate very well. I manage the toxicity. I'm not saying I'm not boasting or blowing my trumpet, but yes, I am comfortable with using TAC and happy with the results.
So would you like to give that message to our younger colleagues that if you have a metastatic breast cancer, you're good to use 3 drugs?
Yes, if the patient is clinically good, physically good, yes. Because one advantage is that instead of giving those 8 cycles, 4 and 4, I would rather finish it off in 6 and see how the patient goes.